Good evening, everybody. Good evening. And welcome to another MS Views and News program. And this program, unlike other organizations, we provide a different style of program, and we do this because we want to benefit those affected by multiple sclerosis, including the patients and their family members and other healthcare providers if they need to learn more about multiple sclerosis. Tonight's program is our 29th program of this year. Exactly. And not only is it our 29th of this year, but it's our 119th since we began in February of 2010. We do this, the pharmaceutical companies like us to do these things. They fund our programs. We need them and other benefactors to fund our programs. They do this because they want the patients to be educated with the information that we are helping to provide. You all can benefit from this, and we hope that you all show this in your evaluations as well. For tonight's program, firstly, we want to thank all of you for coming here tonight, so I want to thank you. Secondly, our sponsors for tonight are Novartis Pharmaceuticals, as well as Questcor, also now known as Mallinckrodt. Mallinckrodt will be the new name that you hear for Acthar Gel, and the name Questcor is going to disappear off into the distance. In addition to the two of them, we want to thank Genzyme, Biogen IDEC, and Teva for their displays that you came and you visited with outside. So if you all don't mind, I would like a little thanks to everybody. So, for those that don't know, Dr. Scott Gold has been practicing here in Melbourne for many, many years. He came up out of Miami, where I believe he was a graduate even of University of Miami. So, we want to welcome Dr. Scott Gold here tonight. Thank you.
Thank you very much. I want to thank Stuart for inviting me to speak today. I'm reminded that I'm on camera and I can't do my usual walking around and picking on people, so you're safe. So I'll have to stay within a certain distance here. It's going to be interesting. Over here? I've already worked on this. Okay. So as you know, we're going to present some information about MS and the invisible symptoms, but we can go off on tangents and talk some about things like can you hear me in the back? Yes. Great. We'll talk about anything you want to hear about. This is your program. This is not my program. We'll be talking about updated treatments, and we'll talk about things from the ECTRIMS meeting and other breakthroughs. So it's an exciting time. Every time I go to the meetings, I get rejuvenated to come and speak and tell you everything I learned. Of course, that may take about 3 hours, so if everybody's got time, I've got time. So. All right. No, I'm not going to spend 3 hours. There's a sigh of relief from everyone. Okay. So as you know, I usually like to start our... before I forget... I can't tell you until we go through some of these slides. But remind me to tell you about some of the things that motivate people with MS to do things that are outside the box, outside of their comfort zone. And Jeff helped me to remember that, so we'll talk a little bit about that after I get through some of the slides. So as you know, after I get back from some of the meetings, I like to show pictures and have I get to do my question and answer and see if you can identify the city where the meeting is from. So here we go. Okay. So these are just some of the disclosures. These are the companies that I've spoken for and also done research with. Okay, so the first question is, this is the city where the ECTRIMS and ACTRIMS meeting was held today, this past couple weeks. And ECTRIMS is the European version, ACTRIMS is the American version, and it's basically meetings devoted to research in MS. This year's meeting was the largest meeting ever. There were 9,000 attendees, most people from Europe, some people from the United States, but we'll talk about that if you like. But does anybody know what city this is so far? Boston. I hear London, I hear Boston. Any other? I'm not going to say. Okay, so this is a city on the river. We're going to go through a couple of these. I'll come back to them. This is a little green in the center of the city. And of course, there's Paul Revere, so that kind of gives it away. And the Minuteman in Lexington. some of the churches, and of course the Fenway Park with the Boston Red Sox. So this meeting was held in Boston, or I should say Boston. They made sure we understood how to pronounce it correctly. Okay, so this is the Charles River. These buildings up in here are the area where MIT and some of the other universities are in Cambridge. Back over here is where the main city is. Right there is the downtown area. Some of the government buildings. This is the Boston Common, the city park. Beautiful area if you ever get a chance to go up. Just don't go much past October because it might not be to your liking. And of course, Paul Revere. So in the back, you know what this structure is in the back? The North Church, correct? Oh, we took the duck tour and people made sure we knew that when Paul Revere rode through the streets, he didn't say the British are coming because everybody was British at the time. So interesting tidbit. Lexington was very interesting. Okay, this is some of the harbor. Anybody know which harbor this is? This is Marblehead Harbor on the North Shore. Anybody know what this is? Gloucester, that's correct. It's not the fisherman on the fish box. This is another harbor along the north coast of Massachusetts and getting into Gloucester and Rockport. This is a bed and breakfast in Kennebunkport, Maine. This is a group of resorts along the shoreline in Maine. And this is Bar Harbor, actually going to Acadia National Park and standing up on Cadillac Mountain taking pictures. So it's really beautiful country if you ever get a chance to do so. Again, you can see how high up we are by the size of the ships, the cruise ships. And one of them was the Queen Mary II. Interesting. I guess on their way up to Canada. This is one of the many lighthouses. The change of season. And this is up in New Hampshire, the White Mountains. So beautiful area, highly recommended. Okay, now we have to get down to business. So everybody really knows what MS is. I'll just give you some of the updates of what we learned from the last ECTRIMS meeting last year. But basically, we already know that it's a disorder or group of disorders affecting the central nervous system. There's inflammation on an autoimmune basis. The myelin is affected, but we also know that the nerve cells are affected fairly early as well. And we know that the axons, which are the thin filaments, can be affected. There are some interesting observations now. We know that in the cortex and the meninges now, there's something called B cell follicles. So these are collections of B cells that are producing damage and are resistant to treatments. And this may be the reason why people are resistant to our therapies or declining. We also know that genetics are important. We used to think that, we should just look for a mutation. If we found the one mutation that caused MS, we could cure the disease. Well, we now know that it's not a single gene. To date, there are 159 genes identified, and they're expecting that over 400 will be identified. They have various gene arrays and so forth. So what they do is they've identified genes that are involved in the autoimmune process. Some of them have similarities to the other autoimmune diseases. Some of them are unique to each individual system. So for MS, we see genes that are unique for the nervous system. In other autoimmune diseases, they're unique to that particular organ system. We also know that it doesn't appear to be one single or group of bad genes or mutations, but rather the interaction between these genes and various environmental factors. So it appears that the environmental factors are playing a bigger role than we ever thought. Things like toxins, tobacco, vitamin D, latitude, viruses, and so forth, all interacting with these various genes seem to produce the multitude of MS presentations. And these are the other autoimmune diseases, just a small sampling throughout the various parts of the body, as you can see. This may be a little hard for people to see in the back, so I'll just point out a few of them. For joints, we know about rheumatoid arthritis and lupus, psoriatic arthritis or psoriasis in the skin, blood vessels such as lupus, the lungs in asthma, GI tract in Crohn's disease, and the pancreas in diabetes. So we know that the myelin around the nerve filaments are being attacked. We used to think that the T cells or T lymphocytes were the primary cell involved. We now know that there's an interplay between T cells and B cells. So those drugs that are designed to be purely T cells, those drugs are designed to be purely B cells, both seem to work quite well. There are some that work on both. So we're learning a lot about how this process works. So they have the activated T cells secreting what are called cytokines, which then attack the myelin. Okay, so I wanted to move on. The diagnosis of MS is difficult, more difficult than people tend to give us credit for. And I think the problem is that you have many invisible symptoms. You have symptoms that are not so obvious, and you also have the symptoms that are pretty classic, such as optic neuritis and transverse myelitis. So the diagnosis is not always typical, or it's not always easy to make because people don't always present in a typical fashion. And most of our research is actually done on adult white men and women, and very little in terms of children, Asian, African, Hispanics. So we have to take that with a grain of salt. And about the difficulty in making the diagnosis, the original diagnosis used to be set up through clinical guidelines. So we used to go by the symptoms, whether people had different kinds of clinical attacks within different space within the nervous system as well as over time. And that's how we made the diagnosis initially. And then in the early 1980s, MRIs started to come out, and we started to learn more about how lesions would show up on the MRI and could be used to diagnose and to monitor patients. In 2001, and then again with revisions in 2005 and 2010, McDonald set up criteria for making the diagnosis of MS in patients who had their first clinical attack. And as we've moved along, we now can make the diagnosis with a single MRI in time based on what we see on the MRI and the MRI appearance. So we have invisible or silent lesions that occur within the brain, and we can also see both old and new lesions that will help us to confirm the diagnosis. Clinical isolated syndrome, as you may know, the four major classic categories are optic neuritis, which is the optic nerve, transverse myelitis, which is the spinal cord, brainstem syndromes, which is brainstem activities such as double vision, trouble swallowing, speech, and so forth, and then stroke-like symptoms in which people can present with sudden weakness on one side of the body that appears like a stroke. Now, we know that a number of conditions will mimic MS, and so that makes things even more difficult. We don't want to just jump the gun and make the diagnosis of MS until we have a little more certainty and that we've excluded some of these other things. They showed MRIs at the meeting that look identical to MS plaques, and it turned out to be non-MS related. So we have to be careful about how we interpret MRIs and the whole picture, and we have to take everything together with information based on blood tests and sometimes spinal fluid. So these are just a rough list of the different things that can look like MS, ranging from B12 deficiency, thyroid disorders, all the way up to things like normal pressure hydrocephalus, motor neuron disease such as ALS. In fact, I just had my second patient in the last few years that was being treated aggressively with different MS treatments and still declining, and it looks like she's going to turn out to have ALS as well based on the nerve conduction and EMG studies. Apologize if I shot the laser into someone's eyes there. Okay, now some of these things we call red flags, and we say that because there are certain symptoms or presentations that are very atypical or very rare for MS. They do occur, but when we see these things, we have to at least think that some of these other conditions may be present that we mentioned. So hearing loss can occur, but it's very unusual in MS. Progressive visual loss, psychiatric symptoms, seizures, peripheral nervous system symptoms in the hands and feet, early dementia as opposed to cognitive dysfunction in MS early that can sometimes present as dementia later on, but that's unusual. Extrapyramidal or Parkinson's symptoms, other systemic disorders outside the typical age group of under 10 and over 55. And then MRI findings that are either normal or showing up as an atypical pattern. MS is often a sporadic asymmetric disease, and if you see an MRI abnormality that looks perfectly symmetrical and shows white matter abnormalities are very symmetric between the hemispheres, we have to rethink the diagnosis. There are certain conditions that we think of as either MS-related or are in the general category. So we think that there are subtypes. Something called NMO or neuromyelitis optica is a condition that often involves the optic nerves and the spinal cord in a particular pattern. There are various spectrum disorders of NMO, and we're defining some things that look a lot like MS but may not be, and they may not actually respond to the same medicines. NMO patients may actually get worse with interferons. ADEM, or acute demyelinating encephalomyelitis, is an acute fulminant, usually post-viral pattern that looks like acute diffuse MS, but it's much more diffuse than what we see, and that can be treated in various ways. There's something called tumefactive MS, which is actually MS, but it presents as a single mass in the brain. It looks like a malignant brain tumor, and when people do the brain biopsy, they find that it's actually demyelinating disease or MS and not a malignant tumor. So we have to be careful about what we see on the MRI. There's something called the Marburg variant, which is very rare but very fulminant and very aggressive MS that can lead to death within anywhere from 6 months to 2 years. I think I've seen probably 1 or 2 patients in my entire 30-year career. So it's very rare, but it's very aggressive. And those are the patients that we have to treat very aggressively. Now we're going to talk about active MS, and that's a little different. MS can be active without being this malignant or fulminant. We talk about clinically isolated syndromes. There are some patients who never progress on to MS and just have an isolated syndrome, such as optic neuritis or transverse myelitis, as we talked about. Bell's palsy, trigeminal neuralgia sometimes can occur in isolation, and Bell's palsy very typically occurs in isolation and doesn't progress into MS. And then finally, there's this newly described term called RIS, or radiographically isolated syndromes. Those are people who have MRIs done for a different reason, such as, let's say, bad headaches or because of head trauma or some other process, and they find lesions that look very typical of MS. And we're going to talk about that as well. Now, these are the clinical courses that we've described for many, many years back in the 1990s based on the initial clinical trials. And over time, we're starting to make some changes in these, thank goodness. In fact, you have not only relapsing, remitting, primary progressive, secondary progressive, but this term progressive relapsing was sort of an in-between category, is now being termed primary progressive MS with activity. And as you can see on this slide, you have different categories going from milder to more severe, CIS or clinically isolated syndromes, relapsing or remitting MS, secondary or primary progressive MS, with and without activity. And that with activity may give us a clue as to how to treat those patients. If they're active, they may still be relapsing, and so those patients may still be candidates for disease-modifying therapies. The problem is that once you start treating patients, it makes it more difficult to define these things, and these were initially based on the trials that led to starting treatment, whereas with these particular patients that are on treatment already, it may not be fully applicable. Okay, there's something called highly active MS, and these are patients that we see coming in that have a lot of activity on their MRIs or clinically, and that can give us a clue as to how aggressively to treat those patients, whether to treat early, whether to treat aggressively with some of the disease modifiers. If the relapses are frequent or severe, particularly if they're occurring while they're on a disease modifier, then those are highly active. Those people who don't recover from their individual relapses, people with multiple systems involved, such as sensory, motor, bladder, bowel, and so forth. Early disabling symptoms, especially those invisible symptoms such as cognitive impairment, severe fatigue, physical findings as well. And then the heavy MRI burden, those people who have lots of lesions, particularly if they're enhancing with gadolinium. And those patients who start out with an isolated syndrome then can progress more rapidly if their MRIs are abnormal. So the MRI can be predictive as well as a useful tool for diagnosis and monitoring patients. And then we know that those people that have a higher risk of higher active disease, men more than women, African American more than Caucasian American. So there are certain categories where we see a correlation, and we try to treat those patients more aggressively. The goals of treatment, as you know, are to prevent the relapses with disease-modifying therapies, treat the individual relapses, try to manage the symptoms as they arise, prevent disability from occurring, stabilizing the MRI as best we can, and of course, improving quality of life, trying to maintain patients as close to normal or at least as stable as possible and improve their level of function. We still know that timing of therapy is very important. So people without treatment will have more disability than if they're treated earlier. And then the earlier we treat, the better the prognosis in terms of lessening disability. The question is, what is early treatment? And we used to think that if someone had their first symptom, that was early treatment. Well, it turns out that there are so much variability in the MRIs. If you look at someone who has their first symptom, and you look at their MRI, a certain percentage of people will have very mild disease. Some people may have normal MRIs. Some people may have horrible-looking MRIs because the disease has actually been brewing and is invisible or silent for many years. So that's the tricky part about MS. And it's not unlike some of the other diseases we'll talk about as well, but the radiographically isolated syndrome has generated a lot of interest because we're picking up patients even before they develop their first true MS symptoms. And we can then tell which patients are at risk to develop more obvious clinical MS. There's about a third of the patients after 5 years will progress to develop their first symptoms. And about 60% of the patients may actually have the McDonald criteria and meet criteria for MS even without symptoms. Okay, I can't see you in the back, so if you have any questions, shout out. So the clinical onset of the first symptoms are difficult. It's easier if someone presents with the classic clinically isolated syndromes, the optic neuritis, transverse myelitis. But it's much more difficult if the symptoms are invisible, quote unquote, with cognitive fatigue, difficulty with bladder and bowel that most people don't realize can be all part of an MS syndrome. And those are the challenges that we have when patients aren't presenting in a classic way, particularly if the MRIs are not yet showing abnormalities. It can be difficult to make diagnoses early. So you go from radiographic to first symptoms in clinically isolated syndromes, the early and late relapsing, remitting, and then into secondary progressive, and eventually to people who are not active but are still progressing slowly. This is to show the atrophy that can occur over time, and that's what we're trying to prevent, is this degeneration in the nerve cells that can occur over time. So you can see that these sulcal markings, which are the crevices, become widened as we lose more and more tissue. The fluid-filled spaces enlarge because we're losing tissue in the deep portions of the brain. And so we're trying to prevent that conversion from the milder phases to the more to the later phases.
Are the symptoms of an atrophied brain different than a lesioned brain?
That's a tough question. The question has to do whether an atrophied brain symptoms are different than a lesion brain, and I don't know that you can mutually exclude them. Most people who develop atrophy also have a lot of white matter lesions, so you can see those abnormalities. Now the problem is that there's not always a very good correlation between what we see on the MRI and what we see clinically. So patients may have one attack or very few symptoms, and their MRI may look very advanced, and vice versa. We know that there's a better correlation between what happens in the cortex, which is the surface of the brain, and when we see atrophy in those areas, then we know that the disability is at a higher rate. But those are very difficult to measure with the MRI techniques that we have available to us these days. So it's a tough question, and we're still trying to sort those things out. Okay, we talk also about the silent diseases. If you think about not only the radiographic isolated syndromes, diseases such as hypertension, diabetes, certain infections, other autoimmune diseases, and metabolic diseases, all can produce symptoms very late, and they may have accumulation of damage to the nervous system through a number of months or years. So we know that high blood pressure over time can lead to stroke and heart attack. It's well known that people can have silent strokes and silent heart attacks. And when you look at certain patients, particularly with diabetes or hypertension, and you look at their brains, oftentimes they've had a number of strokes that they never knew they had. Chronic infections such as Lyme disease or neurosyphilis can present with relatively minimal symptoms early on and then develop into more severe neurologic disorders later on. Lupus can mimic MS in that respect. It can have a lot of the same kinds of symptoms. And then certain metabolic diseases, B12 deficiency can produce a syndrome of dementia, depression, and spinal cord abnormalities with tingling sensations in the hands and sometimes the feet. Thyroid disease, Wilson's disease, which is accumulation of copper due to inability to metabolize and excrete copper. So the problem is that these diseases can occur, they can mimic MS, and they can also be silent for quite some time. So MS is not unique in that respect. And this is a slide that I've used on a number of occasions. I just want to point out a few things that have changed. We talk about some of the different diets that are available. I'm not going to go through those tonight. Vitamin D is interesting in Norway with cod liver supplementation. Ages 13 to 18 seems to lower the risk of developing MS. Exercise, as you've heard, makes a big difference in building brain reserve and improving quality of life and activity. Sleep is important, rest, especially planned rest periods. Mental health is important. They're starting to find associations not only of depression with MS, but also bipolar disorder, schizophrenia, may be a little higher incidence in MS patients compared to the general population. So we have to be attuned to those things, and if those symptoms are present, we have to address them and treat them aggressively. Foreign substances are becoming key. So tobacco use has been shown to have a significant impact in converting patients from relapsing or remitting to secondary progressive MS. So it's that interaction between toxins and tobacco and other environmental factors with the genetic makeup that we discussed. Excessive alcohol, marijuana in large amounts can have cognitive effects, medications, particularly sedatives, and then trying to make sure that we're not missing some of the other conditions that are coexisting with MS. Okay, I'm not going to focus much on acute relapses today because of time. But basically, we know that acute relapses can occur in the vast majority of patients. There are disturbances of a particular part of the brain that last at least 24 hours. There's usually a period of stability for at least 30 days. You have to make sure that there are not other factors such as infections or overheating that are playing a role. And then we want to make sure that we're looking at the frequency and the severity of relapses, whether we're able to keep them down to a less frequent and less severe pattern with our disease modifiers. And then treating the relapses themselves, rest, and particularly in a cool environment, can have a huge impact. Certain symptoms can be part of those relapses. Some of the things that are less obvious to other people, such as cognitive or fatigue issues, are things that are real and important and need to be addressed and treated. And then we have some of the other symptoms that can occur acutely as well as chronically. I'm not going to go through those in much detail. Some of the acute treatments that we have for relapses involve IV and oral steroids. There's an interesting presentation showing that treating high doses of oral steroids can be very effective in helping patients who can't tolerate the IV or don't have IV access. So oral can be very beneficial. Some people have more side effects with the oral in terms of behavioral and GI side effects, but it's variable from person to person. Let me go back. Okay, oral steroids we talked about, and then some of the drugs like Acthar has been very successful at controlling relapses that are resistant to steroids or those patients who don't have good access, and that's intravenous access. And when those drugs are failing, we have other therapies as well, plasmapheresis, IVIG, and other medications. Okay, and we can see that since the 1990s that we now have 11 FDA-approved medications for MS. Back when we only had one, it was pretty simple choice. It was all or none, and if you didn't tolerate it, well, that's the breaks. Now we have so many different choices that if people aren't tolerating a drug, we can move on to other medications. So you can see that the interferons were some of the earlier ones, glatiramer or Copaxone after that, and then we got into some of the oral drugs since 2010, 2011, 2012, Aubagio, Tecfidera, and now a newer interferon called Plegridy. And then there's some other things in the pipeline that are being investigated and are still being studied and still in early stages, but those are looking promising as well. There's a lot out there, a lot on the forefront, and I think it's very exciting to see that we have more and more choices. So if people aren't responding to one medication, we have other options. One of the big areas of research at ECTRIMS has been looking at secondary progressive and primary progressive patients and trying to find medications that will benefit those patients as well. And to date, we haven't had anything that's been definitive. There's one called anti-lingo that's in the pipeline, and that looks promising. But again, we need to, and people around the world are recognizing that we have to research those areas for those patients. One of the ways to try to determine which drug we should use has been step therapy. When William Stewart first proposed this a few years ago, we only had basically 4 drugs, so it was the interferons and Copaxone, and now we have a number of others. So these main drugs are platform therapies, involve the different interferons, Avonex, Rebif, Betaseron, Extavia, and now Plegridy, and those have proven benefit and long-term safety. So when people choose those, they have confidence that that's going to be a safe approach. We also have glatiramer or Copaxone, and that seems to be safer from a pregnancy standpoint. So if someone is considering pregnancy and wants to be on a disease modifier, that's a good choice. Actually, all the drugs have been, not mistakenly, but inadvertently been on board when women happen to become pregnant. And so they follow those patients, and actually surprisingly few people have had difficulty with the pregnancies and with effects on the babies. So that's encouraging. We don't recommend that we stay on the medications necessarily, so if women do become pregnant, we usually are taking them off during the pregnancy itself. Tysabri has been around for close to 10 years now, and for those patients who have more active MS, it might be one of the first line, particularly if they're JC virus negative. About half the population has JC virus, and the population that has it, particularly after 2 years of Tysabri, is at higher risk for developing a brain infection called PML. We have something called an index, which helps us to determine the risk as well. Gilenya, Aubagio, and Tecfidera are the 3 oral drugs that have come up in the last few years. They also look very effective. Gilenya has been used for highly active patients, particularly if they're JC virus positive. Some people are moving in that direction. Aubagio is an effective backup, so when patients are starting with a particular therapy, then if they need something that's stronger or if their therapy is not working, then we have these as a backup. Step 2 involves switching among the different platform therapies. Step 3 means to add in something on top of the therapy, such as steroids of various sorts or Acthar. Tysabri is the only exception because of the TOUCH program. We are not allowed to use it in combination with other therapies long term. And then we can also consider step 4, which is switching to immunosuppressant therapies, which are more aggressive. Okay, I'm going to try to move along a little bit faster here. Some of the updates involve using some of these drugs for other kinds of things. So, for example, the interferons now can be given anywhere from every other day to every 2 weeks. Glatiramer is now up to 3 times a week, but a generic was just studied and found to be effective. That's a daily generic. Tysabri every 4 weeks, and they're looking at that for secondary progressive patients as well. There's something called L-selectin, which may identify those patients who are at higher risk for PML. So all these there's active research with all these various drugs. Gilenya is being looked at for secondary progressive. Aubagio is effective in CIS. Tecfidera is also being used in a number of things, although there are no active studies in those other categories. There's some other therapies that are on the forefront. Ocrelizumab looks very promising as a B-cell therapy, so people can look to that as something that will be available in the next couple of years. And again, a number of other therapies. Estriol, which has gotten a lot of press because it mimics the pregnancy state, has been effective in improving cognitive function, but it seems to be a temporary benefit. Not to mention that estrogen compounds may have other long-term effects as well. Okay. So I'm going to go on. I'm going to skip over a lot of the mechanism of action. Again, there's a lot of T-cell and B-cell effects of these different drugs. And once you get into ocrelizumab, it's predominantly B-cell. And that just shows that we're trying to balance some of the effects in MS. Okay. This is looking at some of the other therapies. There are skin patches with myelin proteins that are being looked at currently. Some other oral agents such as laquinimod. For those people with spasticity, cannabinoid derivatives such as sativa seems to be very beneficial as well. There's also these other infusions either once every 6 months or once a year that look very promising. Stem cells are still being studied. Stem cells are being given a couple different ways. One is to start the bone marrow from scratch by wiping out the bone marrow with immunosuppressants, giving stem cells, and then building back the immune system from scratch, basically. Other studies now are looking at giving stem cells without having to go through the immunosuppressants. Some are given by intravenous route, some are given into the spinal fluid. So again, all those things are being studied, and we should have some information about that this time next year. Again, I think a lot of what we do with the management has to do with monitoring patients to see if they're responding to therapy. Those patients who are still showing new activity on their MRIs after they've been on the disease modifiers for a sufficient period of time, at least 6 to 12 months, those patients have a high risk of going on to developing more severe disabilities. So we are watching those patients closely when we first put them on medication to see if they're responding. So we look at MRI as a big part of it. We look at the various parts of the examination, the EDSS, psychological testing, OCT. There's something called proteinomics, which is looking at various proteins and seeing what the response is. That's still very early, as well as looking at quality of life. So the goals of treatment, really in summary, are basically to look at all the available treatments, see what's available and best for your lifestyle, and discussing those things with physicians. You want to try to adapt the intensity of the therapy to the severity of the disease. So if someone has highly active MS, then it's important to be as aggressive as it takes to try to control that disease activity. And that may be switching therapies, it may be going to fairly aggressive therapies. You have to be realistic that this is not a cure yet, but it's coming close to being a cure in terms of stopping the inflammation and also looking at ways of preventing neurodegeneration and demyelination long term. Okay, we want to make sure we stay positive and be hopeful, because there is a lot to be hopeful about these days. And basically, you want to communicate as much with your physician and family to be able to continue on the right path. You want to build a strong team around you, both in the family as well as the healthcare aspects. You know, and if you are in a particular therapy and you're not tolerating, you don't have to suffer with the side effects necessarily. Talk to your physicians. Got it taken care of. Stuart's giving me the 10-minute mark. This is actually one of the last slides. So if you have a therapy that's not working or that's not being very well tolerated, you want to talk to your physician about either finding ways to help you tolerate the medicines or switching therapies. And as Randy Shapiro, one of the gurus in MS care and who started the first MS center in the country, always says that MS is a marathon, not a sprint. It's not how you start, but how you finish that's important. It's so important when you're talking about these various therapies. You want to find the one that's right for you. And of course, I've never been one to shy away from getting cheap applause, so you want to look at what's really important in life. And this happens to be my granddaughter. And this is actually about a year ago, and in 1 year, she now looks like this. She's actually got hair now. So. Thank you very much for your attention. So we're actually starting the Q&A session 5 minutes early. You can tell. We're starting Q&A. Where have you been?
What happened to 10 minutes?
You said 10 minutes. I said 5.
All right, listen, everybody. I'm going to go around the room with the microphone, and for whoever's got questions, I'd appreciate if you could wait till I get to you, so that way we could hear your questions, and then the doctor will answer. So can I start on this side, and then you'll get me crisscrossing all over? I need to lose a few pounds, so I need you to run me around the room, all right? Anybody got a question?
Hi. Excuse me. I have a question. I guess it's kind of basic, but I know diagnosis can really be difficult, and it's about lumbar punctures. Is that always a definitive way of diagnosing it?
Okay, that's a good question, because I think there's a lot of variability from doctor to doctor. Some physicians feel you have to have the lumbar puncture to make the diagnosis. Others don't use the lumbar puncture or spinal tap except when everything else is questionable. And I probably fall into that second camp. I think you can usually make the diagnosis, particularly if you have active MS, with the MRI, either at the first MRI or repeat MRIs over time. Sometimes just doing an MRI of the spine and not just relying on the brain is enough to help you make the diagnosis. I've had patients where they had a couple different lesions in different parts of the spine over time, and that was enough to make the diagnosis, even though the brain MRI looked normal. So I think that's important to consider the spine as a way of helping to make the diagnosis. I do have a few patients that I suspect probably have MS. I either treat them, which is less likely, or I'll do the spinal tap and evoke potentials as a way of trying to pin down the diagnosis more carefully. One of the things I see a lot of is that people jump the gun and make the diagnosis of MS pretty freely without really a lot of evidence, and I like to try to stick to the criteria as much as possible. We don't want people to be given relatively expensive, well, very expensive drugs that potentially can have harm if they don't have the diagnosis. I think we need to be sure. There are also people who have very inactive disease, who they have MRIs over a couple years and they haven't changed. And if they haven't been on therapy at that point, what are we trying to accomplish with the therapy? We're not going to affect the lesions because the lesions aren't developing in some individuals. What we're trying to prevent is the long-term effects down the road of atrophy and other negative effects of the disease long-term. And that's not always an easy thing to determine. So.
And I have one more about that. Is an LP always positive? And even if you're on therapy?
Lumbar punctures or spinal taps are not always positive. There's some people who feel like if your spinal tap is normal that you don't have MS. That's just not the case. When they did the original studies with the spinal taps, they broke patients down into definite, probable, and possible MS. And those people, even that had definite MS by symptoms and by the exam, had about a 90 to 95% positivity rate of the spinal tap. Once you got down into probable and then possible, that percentage dropped drastically. So again, I use the spinal taps when everything else seems to fit, but we're just not getting a definitive diagnosis, particularly by the MRI, and then I'll go ahead and do the spinal tap at that point.
Dr. Gold, you mentioned at the beginning of your talk about how difficult it was to diagnose MS because there are so many other things that can mimic it. And I have a question in regard to that. I have a cousin who was diagnosed with MS, and that seemed logical in light of the fact that there is evidence of family traits being passed down. But now she says, no, I don't have MS, I have Lyme disease. But they can't really decide which it is. How do you actually determine and eliminate all of the other things before you diagnose the MS?
When someone comes in, and especially for the first time or when they're coming in for a second opinion about the diagnosis, not so much about the treatment per se, those patients sometimes fit the pattern very classically, and I have no trouble making the diagnosis at that point. The problem is there's a certain percentage of patients, perhaps as many as 10%, who don't have the typical findings and that we're looking for alternative diagnoses. Lyme disease, even though it's gotten a lot of press, is pretty rare as a mimicker of MS. We don't see it much, particularly down south. We see it up in the Northeast, particularly up in New York, Connecticut, and so forth. But even there, it's not as common as MS. MS is a fairly common autoimmune disease. The other problem is that we sometimes jump the gun. If someone in our family has MS, doctors are sometimes willing, sometimes too quickly, to make the diagnosis because your relative also has it. I think we have to be careful because even in identical twins, there's only about a 35 or 40% concordance rate, which means in identical twins, the genetic makeup is identical, but as you can see, the environment plays a big role, and so only about a third of the patients will actually develop MS down the road if you follow them. Once you get away from identical twins and you get into father-mother, and then mother-daughter is the next highest, then mother-son, then father-daughter, and father-son. So once you start getting away from identical twins, that falls off dramatically below 10%. So I don't use the family history per se. Now, there are some families where it's rampant, and there are some families that cluster autoimmune diseases, particularly MS, in the same family. And so when you see someone with 2 or 3 or 4 family members with MS, and it's been well documented, then you have to seriously consider the diagnosis. But ordinarily, I don't like to use the family history as a diagnostic tool. I think you have to look at the picture individually and try to determine for that particular person whether they meet the criteria. So I think these criteria are very helpful. I think it's important when we first see someone to look at other diagnoses. We'll check for Lyme titers. We'll check for things like sarcoidosis. We'll look at a number of different conditions, lupus and so forth. So there are other conditions that can look just like MS, and so we have to exclude those first.
Do you feel like, or do you recommend for MS patients to get the flu shot, pneumonia shot, and shingle shot?
Okay. The question has to do, I think, is an important one having to do with vaccinations. There was a time where there was concern about vaccinating patients because they had an autoimmune disease. As it turns out, most patients can be vaccinated I would say the vast majority of patients should receive those injections. Now, the only exceptions to that are people who are on heavy immunosuppressants or who are on Tysabri, where there's enough of an immune suppressant effect that you have to be careful about giving a live attenuated virus. So those are things like shingles, mumps, rubella, measles. I think the nasal form of the flu vaccine is also a live attenuated. So there are certain viruses that we have to be careful of because you can actually give someone the disease if you've suppressed their immune system too much. If you know that someone's going to be starting a therapy that could be a problem, you want to go ahead and vaccinate. Sometimes we'll just check for TB or for shingles to see if people have antibodies against those diseases. If they have active TB, you probably ought not to start too many of these drugs. If people have had enough immunity to the shingles or herpes zoster, then those patients can receive the drugs. Sometimes we'll go ahead and give them the zoster vaccination before we start a new medication.
My question is, I think I'm confused, or I get confused when I read something about the secondary from our most common was to, like, if you had an attack and it seems that your symptoms really never went away all the way, like, for example, it would be like numbness and tingling in the legs. Do I just think that is like a permanent from the attack I had, or could it be maybe progressing to the secondary, or how is that determined more specifically?
You have to determine individually for your particular form of MS, basically, with your physician about what each individual attack means. Most people in the early stages of the disease have a higher attack rate for their exacerbations or flare-ups compared to people who have had the disease for many years. Most people in the early stages will have a full recovery from their attack. So even a very severe attack can lead to good recovery. I have a patient who's 13 years of age, has had a number of awful attacks, but she's recovered now with treatment, and she has very little in the way of deficits, and she's done very well. So even people who have pretty severe attacks very early can recover. The problem is with very aggressive disease and with delays in therapy, patients can go on and accumulate more and more disability. So you get what we call a stepwise decline. They get their attack, so they decline, they improve a little bit, but not completely, then they have another attack, decline, improve a little bit, and they keep having this stepwise decline. And so in a sense, that's a form of progressive MS. And that's that either the relapsing or remitting with secondary progression, or those progressive patients who have activity from very early on. And all these different categories and names we put on things are artificial because we're just trying to describe a very complex group of patients in terms of the way they present. So everybody's very different, and we're trying to pigeonhole them to help us decide what treatment. But it's better to just take each person as an individual and decide what's best for them based on their history, their exam, their MRIs, and so forth.
My question is, I wanted to know, is there other medications other than like Acthar or steroids, IV or oral, that can be used to kind of minimize an exacerbation or to help a medication that you're currently on?
The current therapies, of which there are many, start with the steroids and start with Acthar because they are the best tolerated, and in the case of steroids are less expensive. So we tend to start with something that's lower cost and still effective. For those patients who fail at each step, we then look at other options. So if someone's on steroids and fails steroids or can't tolerate them, then we move on to Acthar because it's the next easiest thing to give. It can be obtained quickly. You can give it yourself. It can be given either subcutaneous or intramuscularly, and it's usually very effective. For those patients who fail there, we then have to look at some other options which are not always optimal. Some of them have to be given in an infusion center, such as IVIG, or in the hospital. Some of them are more risky and much more involved, such as plasmapheresis, which is a whole purification. It's like a dialysis procedure in which your albumin is replaced. And so it gets more and more tricky the further you go along. There's some people who don't respond to any of those, and so we're stuck with just helping them get through as best as we can, and then hopefully prevent further attacks down the road. So it's a real challenge. I think the good news is that the vast majority of people will respond to one of the traditional therapies, the steroids or Acthar.
Any other questions?
Hi, I have a question. You know, MS is demyelating. Is there any drugs that are remyelating?
That's an excellent question. So MS, by virtue of it attacking the myelin, causes this demyelinating effect, which then slows the conduction through the nerves. In the earlier stages of the disease, we had the natural ability to remyelinate. And it's very effective because in earlier stages, the vast majority of patients have good recovery. So that means that they're remyelinating within that period of 2 weeks to about 8 weeks or so. The problem is, as we get further along, it turns out that our ability to remyelinate diminishes. There may be certain effects, such as this anti-lingo, actually helps people to remyelinate for longer periods of time. And so that's the next most promising drug, along with some others, that I think will have a big breakthrough for those patients that we want to try to get them to recover more fully. So you can use it in combination with the medicines for the acute inflammation, maybe long-term to help remyelinate and bring back some of the myelination that was lost. So the one thing we don't have is the ability to regrow nerve cells. And the nerve cells have to be turned back on to start generating those filaments, and they have to generate those filaments just in the right way so that you improve function. There's exciting research out of the Miami project which looks at spinal cord injuries and how to remyelinate, or not remyelinate, but regrow nerve cells around damaged spinal cord. So I think we're learning from some of these other areas of research how to apply it for MS. So that looks very promising. It's just not available as yet. You know, when you think about it, you want the nerve cells to grow, but you don't want them to overgrow, because that means growth, and that means tumors. You want them to grow in the right way and in the right area. So you want them to get to the proper target of going from brain to finger to get them to move, or to leg. So you have to get them to go to the right place, and that's extraordinarily difficult. But there's progress being made.
Any other questions? Okay, see, somebody's going to make me move.
Now, next question will be out in the back here.
Medical marijuana?
Oh, of course, I knew that was coming up. Okay, there is a lot of controversy about medical marijuana when it comes to MS. Not in the minds of patients, but in the minds of researchers. And the problem is, if you look at marijuana effects, even if you take away the effects on the lungs and so forth, it doubles the rate of lung cancer independent of other effects. Smoking marijuana, that is. If you give it in other ways, it probably avoids that. When marijuana is given in high doses over a long period of time, it can cause cognitive decline. We also don't think it has an effect directly on the disease itself. It only affects the symptoms, such as pain, spasticity, and so forth. So I think there will be a role for that. The problem is allowing it to be approved in the states, so then we can then research it more in the United States. I think the problem is that because it's been illegal, quote unquote, we won't go there, but I think because it's been unavailable to the vast majority of patients, and it hasn't been available to researchers by and large in the United States, so we don't really know what the proper dose is, what the proper ingredients should be. This medicine that I mentioned for spasticity out of Europe and Canada, called sativa, looks very promising. And I think that in and of itself will hold a lot of promise for bringing those kinds of agents into the United States. We're talking about using it for things like epilepsy and some other things, and patients tell me that they've used marijuana and find it helpful. We just don't know what the long-term effects are. We don't know what the dosage is. You know, we have to treat it like a drug because our body treats it like a drug, and it can affect us in good ways and bad ways. So I think we have to be real careful and study it. If it becomes available later this year in Florida, the real issue is going to be the devil in the details, so we have to make sure that it's being provided in a way that we can give it safely and that we can give it without too much administrative overburden, which I can tell you now it probably won't be easy. So we'll have to see how they, number one, if it does get approved, number two, if it's released and how it's released.
Anybody else? See you all the way in the back. There you go. You had to name it, right?
That's right. Want to keep you moving forward.
Exactly.
Hi, what are your thoughts on LDR, low-dose naltrexone? LDN, sorry.
LDN. That's okay. LDN, or low-dose naltrexone, has been around for quite some time. It has some effects on narcotics and so forth. It's a narcotic derivative. It has been studied for MS patients. It has not been shown in any of the studies that we've seen to have an effect on the disease itself. It sometimes will have an energizing effect. Some people feel better on it. It does seem to have some effects on neuropathic pain and on people with fibromyalgia, so it may have some benefit there. So if I have MS patients who want to try it, if they're having a lot of pain particularly, then I will use it. I've had mixed results. Some people respond, a lot of people don't. I've had patients who would try it for a year or 2 years, didn't find any benefit, so they went off of it. So most of the people I didn't find benefited, but I think it's something that's safe enough. It has been shown to be safe. The real question is, how effective is it? It can be compounded at various compounding pharmacies around the county, and I have prescribed it, and you know, I don't have any qualms about prescribing. It's just that people need to understand that and be realistic about what the benefits are going to be.
Tandem. What have you heard about Protandem?
Don't know anything about them. But you can send me the information. I'll evaluate it for you.
I'll be seeing you in a few weeks.
Okay.
All right, anybody else?
In the back. She waited for you to come all the way up.
As a neurologist, are you hopeful for the future of MS? With the new medications that are being treated and studied, are you hopeful that people are going to regain function, personally?
Personally, I've been going to the meetings not because they're in beautiful locations, but because I am very excited about the progress that's being made and the research that's being done. I think we've come a long way in terms of people looking at not just the inflammatory side, but the regenerative side. And so that's a huge area of research now that's exploding. It's going to take us a few years before we can really see that research become fruitful, but I'm very hopeful that it will be. I think we still have to keep emphasizing to patients that we want to keep in as good a shape as possible while we're waiting for some of these therapies to arrive. Because if you just sit back and just let the disease take over, if you are depressed and don't deal with that, if you become inactive and don't push yourself to become more active through activity like Jeff had mentioned earlier, I think that's where people make the mistake and just give up. And it's easy to give up when you see yourself decline, but you really have to fight that. So I think if people are proactive, looking at the environmental factors and really pushing themselves, I think we can keep people at a high enough level so that when these therapies are available, we can take advantage and actually gain benefit. So yes, I think there's a lot to be hopeful for.
Any other questions?
Thank you. Thank you very much.
Thank you, everybody, for coming, and we'd like to thank Dr. Gold. He's one of my favorite speakers in Florida. Everywhere. We do most of our programs in Florida, and so, you know, whenever we're doing programs, I like to include him in on them.